Yeah, fine. Arpit, I think it's 9:05. So,
Yes, sir.
yeah, good
Shall
evening,
we start,
friends.
sir?
Yeah, just a minute. I will introduce few points. Good evening, friends. As per the part of the teaching session, so we are today, Arpit is going to cover about the transitional physiology. As we all agree, this is a very important aspect from fetus to neonate, and the transitional phenomenon is one of the important phenomenon which has a lot of importance in our day-to-day practice. And then we will also cover the aspect of the hemodynamics of that transitional circulation. And Arpit will pinpoint some of the echocardiographic parameters during this transition. It is not feasible to cover everything in 45 minutes, 50 minutes. But let's see. Those people who have questions, please put the questions in chat box. We will have a discussion at the end of the session. So, Arpit, floor is yours. You can please start your session.
Thank you. Thank you so much, sir. Good evening, everyone. Am I audible and visible?
Yeah, Arpit, audible, visible, fantastic. Please go ahead.
Yes, sir. Okay. So today, hello, everyone. I am Dr. Arpit. I am DM resident in Department of Neonatology, Bharati Vidyapeeth, Deemed University, Pune. And the topic of my talk today is transitional cardiovascular physiology and hemodynamics in neonates. So in given time to me, I'll be trying to cover fetal circulation, physiological fetal pulmonary hypertension, fetal to neonatal transition, some points regarding placental hemodynamics and transfusion, some salient features regarding transitional circulation in term and preterm newborns, and echocardiographic assessment for hemodynamic monitoring. So I want to start my talk today, and I want to quote Charles Darwin, who said, "It is not the strongest or the most intelligent that survive, but who can best manage the change." So transition is probably the most important and crucial phase in the newborn. So to understand transition circulation, let us first review the fetal circulation. So as in the adults, where the circulation is in series and both the ventricle contract to provide the systemic output, the condition is not same in fetus because of the presence of various shunts. So to start with placenta, where the uterine arteries provide blood flow to the placenta, and through the umbilical and through the veins, through the capillaries, the oxygen and the nutrient is provided to the chorionic villi, and through the capillaries merges to umbilical vein, and umbilical vein carries the maximum oxygen carrying blood and the nutrients. This umbilical vein then 70% of the umbilical venous blood is then flushed into the liver through the portal veins, and then through the right hepatic vein goes to the inferior vena cava, while 30% of this blood is directly shunted through the ductus venosus to the right atrium, and through the right atrium to the left atrium. And this more oxygenated, relatively more oxygenated blood get mixed with the whatever amount of blood coming through the pulmonary vein, get in reaches the left ventricle, and through left ventricle reaches the ascending aorta and supplies the cerebral arteries and the coronary arteries. So the more oxygenated blood is preferentially directly coming to the left atrium through the right atrium and to the left ventricle and supplying the head and heart, while some of it reaches the descending aorta. While the blood that has come from the inferior vena cava, the relatively less oxygenated blood will get mixed with the superior vena cava blood and the right ventricle, and from right ventricle reaches to the pulmonaries. And because there is high pulmonary vascular resistance in the fetus, the most of the blood will get shunted through the PDA to the descending aorta and provide the so the left ventricular output is the head and the coris, while it is mainly supplying the systemic circulation. This blood comes to the aorta and through aorta to internal iliac and to umbilical arteries to the placenta again. So the characteristic feature of fetal circulation, as we already mentioned, it is the parallel circulation with various intracardiac and extracardiac shunts. Both ventricles are working together to provide systemic blood flow. Majority of the right ventricular output is bypassing the unaerated lungs and providing blood flow to the lower part of the body. And to supply the cerebral and coronaries, the more oxygenated blood is directly shunted to the left ventricle through the left atrium and foramen ovale. Now let us quickly see the estimated intrauterine oxygen saturation in the fetus. So to start with, the maximum oxygen will be carried in umbilical vein, that is 70 to 80%. The inferior vena cava has an oxygen saturation of about 40%. The superior vena cava has saturation of 45%, and the blood that is mixed in right atrium has a saturation of about 55%, which reaches the right ventricle, and the saturation in the pulmonary is pulmonary arteries 55%. Now the blood that has been shunted through the ductus venosus through the foramen ovale has a more oxygen saturation of around 65%. This blood reaches the left atrium and the left ventricle and to the coronaries and cerebral arteries, as we just now discussed. The oxygen saturation in the descending aorta is about 60%. Now let us quickly discuss some fetal cardiac outputs. The amount of blood that is received by the right ventricle is around 65% of the venous, of which only 13% is getting shifted towards the pulmonary artery, while rest 87% reaches the ductus arteriosus and to the descending aorta directly. The 35% of the venous return reaches the left ventricle. Of that, around 70% is utilized in supplying just the brain and heart, while 30% reaches the descending aorta through the aortic isthmus. So this is the combined output. Around 63% of the combined cardiac output reaches the descending aorta. Hence, once again, we can see both the left ventricle and right ventricle is supplying the descending aorta, hence systemic blood flow. Of this, around 40% reaches the placenta and 20% is utilized to supply the lower part of the body. So to summarize some of the unique characteristics of fetal physiology, there are right to left shunts as the pulmonary vascular resistance is high through foramen ovale and PDA. There is relatively hypoxemic environment, and there is differential blood flow through the ductus venosus, which is providing most of the left ventricular outflow, and through the inferior vena cava and superior vena cava, which provides most of the right ventricular output. And the pulmonary circulation is high resistance and low flow in the fetus. Coming to physiological fetal pulmonary hypertension, as we know, various stages of lung development in the fetus is embryonic, pseudoglandular, canalicular, saccular, and alveolar as per the different age in gestation. And we know that the fetus is in physiological state of high pulmonary vascular resistance. This pulmonary vascular resistance initially decreases as the lung grows from canalicular to saccular stage as the caliber of the pulmonary artery increases. While at around 30 weeks of gestation, there occurs increase in the chemoreceptor and chemosensitivity, and the sensitivity to the partial pressure of oxygen also increases. And as we just discussed, the fetus is in relatively hypoxic environment. So this is sensitized by the pulmonary vasculature, and the pulmonary vasculature again starts to contract, and there occurs increase in the pulmonary vascular resistance after 30 weeks gestation to 38 weeks gestation. Now at birth, as the baby cries and the pulmonary blood flow increases, pulmonary vascular resistance decreases, there occurs sudden decrease in the pulmonary vascular resistance. But if any adverse adaptation occurs at this period, this may lead to the pathology called as PPHN. Now coming to the transitional circulation, it is the most crucial phase in the newborn's life, and various biochemical, mechanical adaptations are happening throughout the in various system of the body, especially respiratory system and cardiovascular system. So there is no clear-cut definition as to whom we call in what particular hours we call transitional circulation, but it is usually the period of time when fetal circulation is getting transformed into the neonatal phenotype, as we'll see in further slides. So the two most important event that transits the fetus to neonatal transition is the magical breaths taken by the newborn in the form of cry that we all love to hear, and the clamping of the cord, which suddenly increases the systemic vascular resistance in the fetus. So as the baby cries and takes few breaths, suddenly the ENaC channels that are now that was secreting the ENaC channels, which were sodium secreting, get converts into sodium absorbing mode, and it absorbs the water. The air replaces the fluid with replaces the liquid in the alveoli to air, and the shear stress in the pulmonary alveoli causes the release of nitric oxide. And through some vagal stimulation also, this air that is getting inside the alveoli increases the pulmonary blood flow as well. So this increase in the pulmonary blood flow, this decrease in the pulmonary vascular resistance, with this increase in the pulmonary vascular resistance, now the pulmonary vasculature, which was initially not receiving any blood, will now start receiving blood through the right ventricle, and the shunting through the ductus arteriosus will now stop. This increases the pulmonary blood flow that has increased will now transforms into the left atrial preload and the left ventricular preload. And now as the left-sided blood flow is getting increased, there occurs the closure of patent foramen ovale as well. As soon as we clamp the cord, there occurs decrease or stoppage in the flow of umbilical, decrease in the ductus venosus flow, and the ductus venosus will also get constricted. So to summarize the events, after the cord clamping, the placental low vascular resistance placental circulation is eliminated. And with the few breaths that the baby takes, there occurs 5 to 10 folds decrease in the pulmonary vascular resistance, which causes reversal in the ductal arteriosus shunting, which was initially right to left, will now become bidirectional and then left to right. There occurs rise in the partial pressure of oxygen and fall in the prostaglandin levels as the increase in the PaO2 and decrease in the removal of the placental circulation. The ductus arteriosus will close. The increase in the pulmonary blood flow will cause increase in the filling pressure of left atrium and left ventricle, and finally the closure of foramen ovale, or the direction becomes left to right. These events causes the transition of fetal to neonatal circulation. Now, to graphically represent the pulmonary vascular changes during the transition, as we already discussed, there is the lung is filled with the fluid, and there are low levels of pulmonary vasodilators such as nitric oxide and high levels of pulmonary vasoconstrictor. So the vascular resistance is high. pulmonary vascular resistance is high, and as soon as the transition occurs, as the baby takes breath, there occurs 5 to 10-fold drops in the pulmonary vascular resistance, and this decrease in the pulmonary vascular resistance occurs. This fall continues to occur for the next 6 weeks also. Now, to see the balance between systemic vascular resistance and the pulmonary vascular resistance ratio in fetal, transitional, and neonatal circulation, as well as the fate of shunts during this transition. So we know that during the fetal period, there is high pulmonary vascular resistance and low systemic vascular resistance. So due to high right-sided pressure, the shunts functions from right to left. While during transition, as the pulmonary vascular resistance is falling and the systemic vascular resistance is increasing, during the initial 10 to 18 hours after the birth, the shunts now operate either bidirectional or becomes left to right. So how the shunt functions bidirectional? After the contraction of the right ventricle, the systolic wave, the early systolic wave reaches to the pulmonary side of the duct first, and the blood flow is towards the right to left. Now the systolic wave of the left ventricle will now reach the aortic end of the duct and will cause the shunting towards left to right. So the initial part of the early systole, in the early systole, the blood flow is towards the right to left, and in the late systole and diastole, the blood flow is towards left to right. Hence, the duct is functioning bidirectional. As the neonate, during the neonatal period, there occurs a constant decrease in the pulmonary vascular resistance, and the shunt continues to grow from to left to right. Now, let us discuss some hemodynamics and transfusion related to placenta. As we know, placenta is a unique organ, as in it receives blood from both fetus and mother. The fetus having some the chorionic villi, two types of chorionic villi is formed by the fetus. One villous chorionic villi, one villous trophoblast, which forms the chorionic villi, and extravillous trophoblast, which encroaches the spiral arteries of the maternal side and makes them and increases their caliber and makes them low resistance. So placenta is the principal site for gaseous and metabolic exchange for the fetus, and the fetoplacental unit holds about 110 ml per kg of blood of the fetal weight. And it has been found that the blood flow in the umbilical cord continues for many minutes after the birth. So placental transfusion essentially refers to the net transfer of blood to the baby between birth and cord clamping. And it can potentially lead to the net movement of around 25 to 35 ml per kg of blood from placenta to the neonate. Around 50% of which occurs in the initial first minute only. While if we delay it to at least 3 minutes, around 90% of this transfusion occurs. So is there actually any logic for delayed cord clamping? Let's look. So let us see the cardiovascular changes with immediate cord clamping first. So now the baby is born, the baby has just started to breathe, and the fluid is just getting cleared from the alveoli. It is just in the process. The pulmonary blood flow has not yet increased to supply the left atrium as the preload and left ventricle as the source of preload. And we have clamped the cord immediately as well. So the umbilical venous blood flow that was initially acting as a source for the left atrial preload and left ventricular preload will now be suddenly decreased. So loss of umbilical venous blood flow, it decreases the preload, and we have clamped the cord, which has increased the systemic vascular resistance and increases the left ventricular afterload. Both of these phenomena will decrease the left ventricular output and the cerebral blood flow, which we do not want in a neonate during transition. So it reduces the immediate cord clamping, reduces the venous return to the heart by 30 to 50%, increases the arterial pressure suddenly by about 30%, decreases the cardiac output by the ventricle around 30 to 50%. And this cardiac output by the ventricle will remain low until the ventilation commences and the pulmonary blood flow increases. Now let us see what happens if we delay the cord clamping. So now I have not clamped the cord yet. The umbilical venous supply is still there through the right atrium, through the foramen ovale to the left atrium. And now the breathing has commenced. The pulmonary blood flow has started increasing, and this pulmonary blood flow will ultimately through pulmonary vein will supply left atrium. Now, after the pulmonary blood flow has set in, now you have delayed, because we have delayed the cord clamping, this pulmonary venous blood flow can take over as the source of left atrial and left ventricular preload. So it does not decrease the left ventricular output. So with lung aeration, there is increase in the pulmonary blood flow, intact umbilical cord supply as a venous return and ventricular preload are maintained, and pulmonary blood flow can immediately take over the role of supplying ventricular preload. So there occurs stable left ventricular output and cerebral blood flow if we delay the cord clamping. So many researches have been done regarding delayed cord clamping versus early cord clamping and their effects, umbilical cord milking and umbilical cord delayed cord clamping, like that. The discussion of which is beyond the scope of today's discussion. But to summarize, the delayed cord clamping helps in decreased hospital mortality, decrease in low Apgar at 1 minute, decreased need for blood transfusion in infants, and improvement in the motor functions at 18 to 22 months of corrected gestation age, while there are no benefits to mother and newborn if the immediate clamping, rather it interferes with the physiological redistribution of the blood. So International Liaison Committee on Resuscitation and European Resuscitation Committee recommends delayed cord clamping for at least 1 minute in all vigorous terms and preterm infants. Now, let us quickly see some transitional circulation changes in the term and preterm neonates, which will essentially the crux of what we have all in a term neonate. If the cord clamping is done before lung aeration, there is sudden loss in the venous return to the left and right ventricles, which causes reduction in the cardiac output. And if the clamping is done, the increase in pulmonary replaces the loss of preload by cord clamping. Regarding myocardial contractility changes, the neonate has less myocardial mass, and the organization of myocardial mass is somewhat different neonate in comparison with infants and adults. And as we know, the cardiac output depends on heart rate and stroke volume depends on contractility and the preload. It is the preload which is the predominant contributor for the cardiac output, not the changes in contractility in neonates. So regarding afterload changes, it again depends on cord clamping and lung aeration. If the clamping is done before lung aeration, there is sudden loss of low resistance placental bed and increase in the systemic vascular resistance, leading to increased afterload for the left ventricle. And if we clamp the cord after lung aeration, the decrease in the pulmonary vascular resistance, there is a reduction in the afterload for right ventricle. Now, the preterm neonates may find some difficulty in transition because of some salient features in them. So the preterm neonates are more likely to have some respiratory pathologies like respiratory distress syndrome, which makes their lung less aerated, and the pulmonary vascular resistance does not decline as we expect them to decline. There are some underdeveloped pulmonary vascular bed as well, which again leads to less decline in the pulmonary vascular resistance. And both the above factors will now cause the increase in afterload for right ventricle and decrease in the preload for left ventricle, leading to the decreased cardiac output in preterm neonates during transition. Clamping of cord increases the left ventricular output, left ventricle afterload in the premature neonate, and as their myocardium is immature and the decreased left ventricular preload, which will cause the decreased left ventricular output in preterm neonates. Now, we have seen in the previous discussion that most of the shunts are getting closed, at least functionally, during the transition, but this is not true with the preterm neonates, especially less than 28 weeks gestation. And this persistence of the fetal shunts will again cause maladaptation in the transition to from fetal to neonatal circulation in premature babies. So, to enlist some of the disorders of transition, the disorders of transition will occur wherever there is failure to drop in the pulmonary vascular resistance or there is increase in the pulmonary vascular resistance. As we just discussed, RDS causing acute persistent pulmonary hypertension, and some other conditions like meconium aspiration syndrome, pneumonia, sepsis, hypoxia and acidosis in the asphyxiated neonate, pneumothorax, and some other congenital heart diseases. So how do we do the hemodynamic monitoring of neonate during transition? We have to look out for some clinical parameters. Obviously, to start with, there may occur tachycardia in the neonate, the urine output may decrease, CRT may be prolonged, there may be raised lactates in the neonate. The neonate may fail the pulse oximetry test. There may be increasing in the oxygen requirement in the neonate. Neonate may have signs of respiratory distress and fluctuations in the blood pressure as the later event. So what hemodynamic monitoring devices do we have? So we have a device called as NIRS, which is near infrared spectroscopy, which actually measures the regional tissue oxygenation through various probes that we put in the cerebral region, intestinal, to look at the intestinal supply, renal supply, and the muscular supply. And there is one other hemodynamic monitoring device, which is called as ICON, electrical cardiometry or electrical volumetry. And then there is echocardiography, which is most easily available and non-invasive tool for transitional physiology. We can easily assess the status of our shunts. We can easily assess the maladaptations that may be caused by persistent pulmonary hypertension or perinatal asphyxia or prematurity, as we discussed. So now let us see the echocardiographic assessment and the parameters that we can use. So in echo, the key areas to focus are cardiac functions and cardiac outputs, pulmonary pressures, and presence and direction of flow in the fetal shunt. Let us see some echocardiography during normal transition, and if the baby is not transitioned well, how can we recognize it? So this is the apical chamber view. I can easily assess the contractility of the ventricles through just eyeballing, through just the visual inspection. And I can see whether the chambers have enough blood, as I can see here, and whether any chamber is dilated more in comparison to any other chamber. I can check for the right ventricular fractional area change. I can see the right ventricular systolic function through tricuspid annular peak systolic excursion. I can see the drainage of the pulmonary veins and the D wave velocity. And I can see a TR jet, tricuspid regurgitation jet, which is a marker of PPHN in this apical 4-chamber view. Now let us see one by one. Now, please, can you appreciate this, this contractility through only eyeballing? See the contractility of a neonate which is transitioning normally at 6 hours of life versus the contractility of this neonate, this asphyxiated neonate at 6 hours of life. You can easily assess the decreased myocardial contractility in this baby. Now, as we discussed during transition, there occurs decrease in the pulmonary vascular resistance, increase in the pulmonary blood flow, and this increase in the pulmonary blood flow translates as the increase in the left atrial preload through the pulmonary venous drainage. So in this four-chamber view, apical four-chamber view, we put a Doppler here at the pulmonary vein, and we assess the D wave velocity, and through which we can assess if the D wave velocity is adequate, which indirectly tells us that the pulmonary blood flow is good. Now to assess various outputs, this is the apical 5-chamber view to assess the left ventricular output, and we put a Doppler here to check this VTI, velocity time integral, which essentially tells the how much of the blood is propelled in that particular time. So by putting the VTI and the aortic diameter in the formula, we assess the left ventricular output. This is the right ventricular output can be assessed in many views. We have taken this right ventricular 3-chamber view to assess the right ventricular output. Similarly, we have assessed the right RVO VTI, and through which we can assess the ventricular output. So the normal ventricular output that we consider usually is 150 to 300 ml per kg per minute. And the ventricular output that we have assessed in this baby at 6 hours of life transitioning well was around 140 ml per kg per minute. Which is normal for this age. Various studies have been done during 2nd hour of life, 6th hour of life, and various numerical values have been given so as what to take as normal. So if I take absolute value 140, it may sound abnormal, but it is normal for a baby transitioning at 6 hours of life. So let us see the role of superior vena cava flow in presence of shunts. As we know, if there is shunting, the right ventricle and left ventricular output is not the absolute ventricular output that is received by their respective atrium. So now, if there is persistent, foramen ovale is shunting from left atrium to right atrium, then there occurs increase in the blood flow in the right ventricle, and right ventricular outflow may not be the exact value which is the right atrium is receiving. Now, if the ductus arteriosus is functioning from right to left, there occur increase in the pulmonary blood flow, which will translate as increase in the left atrium in preload and left ventricular output. So if we assess right ventricle and left ventricular output in presence of shunts, that may not give the exact value, exact systemic blood flow. While the blood which is coming from the superior vena cava to the right atrium is not getting diluted by any shunts, so the superior vena cava flow can be used as a good marker for systemic blood flow. Now, again, a right ventricular 3-chamber view, we can assess the tricuspid regurgitation jet. Here you can see there is some amount of tricuspid regurgitation jet, and if I put continuous wave Doppler here, I can assess my pulmonary pressures are around 30 to 35. So you may consider this pulmonary pressures as high, but according to various articles, this baby is transitioning and at just 6 hours of life. So up to pulmonary pressures up to 30 are normal for this age. Now look at the maladaptation. This is the Doppler image that I had just shown, showing pulmonary pressure of around 30 at 6 hours of life. While look at this Doppler of a baby having meconium aspiration syndrome, diagnosed as meconium aspiration syndrome, and having pulmonary pressures of around 82 at 96 hours of life. So we can assess the maladaptation using echocardiography easily. Similarly, look at the nice round left ventricle in a neonate transitioning normally in a parasternal short axis view. While if the baby is having persistent pulmonary hypertension for some reason, there is increase in the right ventricular pressure, which causes bulging of the interventricular septum into the left ventricle, and the left ventricle is looking like a banana shape, which we can assess in the parasternal short axis view. As I already mentioned, the TAPSE, which is tricuspid annular plane systolic excursion, is actually a measure of a systolic function of right ventricle. The tricuspid valve is the medial attachment is somehow fixed, while the lateral attachment moves towards the apex, where we put an M mode in the echocardiography and we assess the TAPSE. This is how a normal TAPSE looks like versus a baby which is having right ventricular dysfunction, having an poor systolic function. Now we can assess the shunts as well. Presence of PDA, patent foramen ovale, and right ventricular dominance is usually there if we perform the echocardiography soon after birth or in the presence of delayed adaptation to transition. What happens to the PDA during transition? In the fetal life, it is right to left as we see, and within 10 minutes of life, it becomes either bidirectional or left to right. If we are finding persistent right to left shunt over 30% of the cardiac cycle, we should always look for PPHN or any duct dependent lesions. Similarly, the shunting in the patent foramen ovale is right to left in the fetal period, which becomes left to right or bidirectional immediately in the transitional period. And if we are finding any pure left to right shunting through the foramen ovale, we should always look for congenital heart diseases like TAPVC or tricuspid atresia. Now look at the nice bidirectional flow in the PDA in a ductal view. After putting this is how a PDA looks like in a ductal view, and after putting Doppler here, I can find very minimal right to left flow, and all of the flow is just left to right, which is normal for this baby during 6 hours of life having a normal transition. Now compare this bidirectional flow to this completely blue flow, which is purely right to left in a baby having severe PPHN. So normally left to right, normally Doppler in the PDA, which is left to right, looks like this. Comparing with the Doppler in the baby we having right to left duct, looks like this. So flow in the patent foramen ovale is assessed in the subcostal view, and this baby had a bidirectional flow in the foramen ovale, which is normal during the transition. So if the baby is not transitioning well, and if there is any adverse adaptation in case of PPHN that we have already seen, there is increase in the pulmonary vascular resistance and increased TR-jet. The interventricular septum shape we can assess. The various shunt flow which are normally left to right during the transition becomes right to left in PPHN. And there is right ventricular hypertrophy which we can assess, and TAPSE as a function of right ventricular systolic function we can assess using echocardiography. While some of the issues that premature babies have during their transition, their myocardium is immature, their shunts are still functioning, they have a faster heart rate, they have inadequate adrenergic innervations, and they suffer from many respiratory conditions like RDS. And in the perinatal, in the setting of perinatal asphyxia, the myocardial ischemia, there is myocardial ischemia and myocardial dysfunction and hypoxia and acidosis as well, which affects the normal transition from fetus to neonatal transition. So to summarize my talk, transitional circulation is a crucial phase in newborn's life, and adaptation to fluctuations in pulmonary vascular resistance and systemic vascular resistance at birth is the key to successful transition. And Echo is an easily available and useful tool for monitoring transitional hemodynamics. And neonates with abnormal transition need good hemodynamic assessment for cardiac functions, outputs, and status of the shunts. Thank you all.
Fantastic. Thank you, Arpit, for covering the topic from fetus to neonatal transition. Any questions that can be put into the chat box, or any points can be discussed from any member, that would be good. So I think this transitional circulation is one of the important aspects to understand the basic fetal and neonatal physiology. And I think India has a lot of potential to work on that transitional circulation research. I'll just add a few points here. India has the more potential about checking this transitional circulation when we talk about the transitional circulation in cases of meconium aspiration, transitional circulation in cases of growth restriction, transitional circulation in cases of asphyxia, transitional circulation when we are dealing with the neonatal sepsis, early onset sepsis, chorioamnionitis. These are the things has not been documented from the West. So it is a very important aspect as a research questions, as we all are here along with discussion, theoretical discussion. That's fine. So that would be the important fact. Arpit, can you take back to your slide? They want to know about the pulmonary vein Doppler, which is the D wave. So just that will be better option when we want to show them the pulmonary vein Doppler, which is the S and D wave. That would be the that's one. So in this view, this is the apical 4-chamber view. This is the apical 4-chamber view where you can see the that's the pulmonary vein. And once you put a Doppler, you will see S wave, D wave. Show them S wave below. That's the S wave, and then there is a last portion is the D wave. The D wave indicates basically whether the flow is decreased, whether the flow is up. Naturally, in cases of the preterm PDA, there is an increase left atrial blood flow, increase LV preload, the D wave will be up. In cases of the pulmonary hypertension, the D wave velocities will be problematic because of the pulmonary resistance. So that's the importance about the D wave. And pulmonary vein Doppler is one of the marker of pulmonary overcirculation in PDA. If you know the markers of pulmonary circulation, then we do count as a D wave velocity as the marker. So that's the question somebody has asked. I think one of the member, Amit, has asked about the D wave. So that's the important about the D wave velocity in neonatology. We can also assess the D wave velocity in the term baby with the pulmonary hypertension, which is one of the marker of ventricular dysfunction, but that's not a part of discussion today here. It's just a transitional part of the discussion. So friends, this is what we all should think when we think about the transitional circulation. We all can think about the research on the transitional circulation. We don't have the data about the transitional circulation and dobutamine in India, transitional circulation and milrinone in India, transitional circulation and the use of the adrenaline, non-adrenaline when there is issues. Those could be the additional factors as the research component. So I think Arpit has covered the theoretical aspect about fetal pulmonary hypertension. He has covered about the shuntings. He has covered about the placental transfusion hemodynamics, and he has covered about the echocardiography. And I did talk about 2 minutes about the research. Any more points? Any more questions? Welcome. And any members, they can put their views. That would be great. Wonderful. Looks like no more questions, no more points. So thank you, Arpit. Time to say good night.
Thank you so much, sir.
Yeah, time to say good night to all team members. See you. Good night.
Thank you, everyone.